Namaste. Thank you, Tony, for making me a part of this instruction course, and it's an absolute privilege to be a part of the forum with such eminent national and international cornea specialists. So, Tony asked me to talk about appropriate patient selection as for someone who is about to start doing keratoprosthesis surgery. So I think there are two important questions that need to be addressed right at the beginning. One is, what kind of patient needs keratoprosthesis? And the answer is fairly simple. A patient who has corneal blindness with a relatively healthy posterior segment, that is some amount of visual potential, and a patient in whose case, in that particular eye, corneal transplantation has either repeatedly failed or is very, very likely to fail. It might either be a very high risk of rejection, or risk of recurrent epithelial problems, or risk of recurrence of pathology, like for example, patient with GLD. And then, which keratoprosthesis? So, you may be aware that there are many, many different types of keratoprosthesis, and these are just a few of the ones that are being currently implanted in the world over. If you look at the top left, I have mentioned some of the numbers of this. These indicate the number of procedures that I have done. So I have experience with 3 different types of keratoprosthesis: the Boston type 1, the modified osteodontoclaw, and the LVPEI keratoprosthesis, which is a new design which we are trying out at Hyderabad at present for patients with chronic Stevens-Johnson syndrome. But different groups in different parts of the world implant different types of keratoprosthesis, and sometimes the indications are not overlapping. Sometimes surgical techniques are radically different. For this instruction course, I think we're going to focus mostly on the Boston type 1, which is the most commonly implanted keratoprosthesis device in the world. And currently, I think there are 3 different variants of the Boston type 1 that you could get commercially. The Lucia, the conventional Boston type 1 from Boston, and of course the Kpro, which is made locally by our lab. All 3 of these keratoprostheses have essentially the same design, and for all practical purposes we will have the same indicators and the same surgical procedure. Our limited experience in using the keratoprosthesis, or the Kpro as it is called from our lab, over the last couple of years has shown that at least in the short-term outcomes, at least at the 1-year stage, the outcomes don't seem to be any different from the conventional standard type 1 keratoprosthesis that we get from Boston, and which is very encouraging. Of course, we have to wait longer to see what the long-term outcomes look like, and if there are any issues which are different from the conventional Boston type 1 keratoprosthesis. Now, I'll go over this a little slowly. How do you select a case that is suitable for a Boston type 1 keratoprosthesis? Now, this is, we refer to this as the LVPEI algorithm, and this is what we follow in selecting our cases and how we decide on which patient gets what kind of surgery. So if you have a patient with unilateral corneal blindness, where the patient has one good seeing eye, we look at what is the visual potential of the blind eye. Do they have some potential of vision or they do not? And if they do, then we look at whether the surface is dry or wet. If the surface is wet, then we usually try something else. We do a keratoplasty with or without a liver septum transplantation if required. If the patient has unilateral problem and their eye is either dry or the eye does not have visual potential, we usually do not try any visual rehabilitative surgery in that eye, leave alone keratoprosthesis. So we will probably give them some kind of a cosmetic solution. If it's a patient with a bilateral corneal problem, or it's the only eye with visual potential, only eye of the patient, and which has a corneal problem, then you think of doing a Boston type 1 Kpro if the eye is wet, which means the patient has good tear function, the lids are alright, there are no major issues with the lid, no exposure, no lid lag, no notching, no ectropia, etc. There's enough space for the contact lens to sit, the contact lens is etc. If the patient has bilateral blindness or only eye which has corneal blindness and the surface is dry, there are several different kinds of keratoprosthesis that you can try in those cases. There's the modified osteodontoclaw keratoprosthesis, Kpro keratoprosthesis, and of course now we are in trial with using the LVPEI keratoprosthesis. And of course, if there's no visual potential, no matter how bad or sorry you feel for the patient, you shouldn't really attempt to do any kind of surgery. So what could be your ideal first case? If you're starting off and you want to do the Boston type 1, I would say choose a patient with bilateral corneal blindness who has a wet ocular surface. So I'm kind of repeating myself, but it's very, very important for you to understand this. Someone who does not have any severe lid abnormalities in their eye, especially look for exposure, look for entropion. Also for entropion, because the drops that you might put may not actually be effective if the patient drops that will just spill out of the eye. And also look if the patient has enough space or needs surgery to create space for the contact lens to stay on their eye. It's very important post-operatively the patient is able to maintain the contact lens. And also a patient who understands the risk. Now, here's the tricky part. A keratoprosthesis is not a permanent solution. No matter which design of keratoprosthesis you're using, if you give the keratoprosthesis enough time, it's going to come out of the eye. So the patient has to be on follow-up, regular follow-up, long-term follow-up, and should be in a position to come to you whenever there's a problem, because you will be needing to take these patients up for secondary surgeries, management of complications. There will be several issues post-operative. So doing a keratoprosthesis is just the beginning of the road for these patients. So the patient must realize this, and as a surgeon, of course, you must know this. And also, you must explain to the patient that there could be need for additional surgeries post-operative. There could be immediately in the post-operative period, there could be later on, but there's a very, very high chance that the patient will need additional surgeries to maintain or to improve the vision. So what are the prognostic factors? This is a slide that I borrowed from my mentor and friend Jim Chorosh from Boston, and I like this slide because it kind of divides the prognostic factors into three groups: the best, the intermediate, and the worst. The best group, and this is mostly from Western literature, are patients with graft failure, multiple failed grafts, and also patients who have aniridia-related keratopathy. Intermediate are those with ocular burn-induced limbal stem cell deficiency. So this could be chemical burns, these could be thermal burns, complicated ocular surface problems because of these burns. And the worst case scenario is when you have patients with corneal problems from autoimmune diseases like lupus nephritis, Stevens-Johnson syndrome, or toxic epidermal nephrolysis sequelae, or patients with chronic uveitis, etc. And in our scenario in India, I think you get patients, the higher volume patients are of ocular burn-induced limbal stem cell deficiency, which is very different from what it is in the West, where most of the patients who would be suitable for such a procedure would be multiple failed grafts. So this is a very, very important consideration. And if you avoid patients who have autoimmune problems, you will help yourself avoid most of the complications that are associated with the type 1 design. So I think it's very, very important that somebody who's starting off in this keratoprosthesis practice to avoid patients who have autoimmune corneal problems. So even though you have a patient with Stevens-Johnson syndrome sequelae, who has deep cornices, who has wet eyes, probably will be able to put a contact lens, is not end-stage disease, I would still say don't fall into the temptation and do a type 1 keratoprosthesis in a patient with Stevens-Johnson at the beginning. If you're more experienced, once you have some amount of experience behind you, you might think about doing it. But by the time you realize what are the things that you could get into. So Boston Kpro with limbal stem cell deficiency. This is one of the papers, one of Tony's papers. What is important here is to know that if you remove the cases, and it's done that in the analysis of Stevens-Johnson syndrome, the retention rates actually become better than in non-LSCD patients, which is a very, very important thing. So Stevens-Johnson syndrome is not a good case to do a type 1 keratoprosthesis, especially if it's in the early part of your practice. And in failed grafts, usually the success rate is the best. It depends from study to study. For example, in this multi-centered Boston type 1 keratoprosthesis study, they had around 50% of the patients with failed grafts, which did well. Similarly, again, this is Tony's paper on improving outcomes and expanding the indication of the type 1 keratoprosthesis, where around 2/3 of these patients were failed grafts, and again, they did very well. We have some data now, and we have been doing the Boston type 1 keratoprosthesis since 2009, so we have around 5 years of data, and we have a good number of patients with 1 year or more of follow-up. And I can tell you this, so if you look at these two cerebral curves, the one on your left is which what compares primary keratoprosthesis in patients with limbal stem cell deficiency. These are patients with bilateral chemical burns who present to you, and without doing any kind of limbal stem cell transplantation or keratoplasty, straight away into a Boston type 1 keratoprosthesis in these patients, versus in whom you attempt an ocular surface reconstruction first and then try a Boston type 1 keratoprosthesis. And what we have found, and this is very interesting, is that the outcomes are very similar. In fact, primary keratoprosthesis tends to do a little better in terms of visual function and in anatomical functional outcomes. And again, if you look at non-limbal stem cell deficiency indications, you will find that even there it's very comparable with the ones which have limbal stem cell deficiency. Of course, here we're not talking about, as I said earlier, we don't do type 1 keratoprosthesis in Steven Johnson patients at all. So in failed grafts and in limbal stem cell deficiency, both of these indications, our outcomes as a group, we started doing keratoprosthesis not very long ago, has been more or less comparable. And right now, we actually recommend the Boston Kpro as a primary corneal procedure in bilateral limbal stem cell deficiency with wet surfaces, instead of going through the roundabout process of trying to deconstruct the surface first, doing allogenic limbal transplantation, keratoprosthesis, etc. It really doesn't help much. A lot of people would say unpublished data, but I'm more optimistic, so I call this one to be published. Again, this is a paper that many of the people who will be talking in this instruction course published along with Tony, the global results of Boston Kpro, and you find that the anatomical functional success is very comparable between surgeons in other parts of the world versus those who operate in the United States, except for the occurrence of endophthalmitis, but it's not alarmingly high, but that's something that should be kept in mind. So, would you choose a child as a patient, as somebody who think of doing a Boston type 1 keratoprosthesis? There are many issues in children, and the most important aspect is in assessing visual potential. There are many conventional ways of doing it. Check for light perception, projection of rays may not always be reliable in children. They have to understand what exactly you're trying to do. A B-scan might tell you there's some gross posterior segment pathology, but you miss scapular pathologies, you miss an optic disc cupping if it's there. And a DEP, if it's positive, that's nice, but if it's negative, it doesn't really rule out a lot of things. It's not always very reliable. So you can use some unconventional methods to assess visual potential, especially in children. So what was the age of onset of blindness? Is there a chance that the patient might be amblyopia? Which eye lost vision first? So this is a very important consideration which is completely different from adults. In adults, you would like to operate on the worst eye first. But if you're operating on a child, you would like to operate on the better eye first, because the worst eye is probably more densely amblyopia than the better eye. So if the patient has like counting fingers, vision in one eye and light perception in the other, you're probably better off operating on the counting fingers eye. But whether you want to operate on a child at all is a completely different question, which is more important. So fixation of light, looking at if the patient has nystagmus, if the patient has had a graft before, what kind of visual activity that patient achieved with that graft, and if there's any previous documentation of fundus finding, or you can take a step back, do a trial of making keratoplasty first, refract the patient and see if the patient vision improved before doing something more dramatic like a keratoprosthesis. So there's very little information available in the literature on pediatric keratoprosthesis. There's this paper by Professor Kpro, where he's done the Kpro and the Boston type 1, and where he said that the outcomes of the Boston type 1 were better, the retention was better, some patients did achieve good visual acuity, but many patients remained amblyopia, and their vision, although they retained the prosthesis, they just had hand motions or light perception. So I would say, in summary, bilateral corneal blindness with wet ocular surface is your best bet. These could be patients with multiple failed grafts, or these could be patients with bilateral limbal stem cell deficiency who have otherwise good lid function and good tear function, and patients who need visual rehabilitation. There are many blind patients who are well adapted to the visual handicap. You know, they can read braille, they work, they use low vision aids, and they are happy. And I don't think you need to unnecessarily introduce complication into their lives by doing something as dramatic as the keratoprosthesis. So multiple failed grafts or post-ocular burn, limbal stem cell deficiency would be your best bet. Make sure that the patient understands the risks of this procedure, and that is why I am very, very reluctant in doing a keratoprosthesis in a child, because the child himself or herself does not understand the risk and is not capable of self-care. Patients who are capable of taking care of themselves are probably better patients to start off with. And as a beginner, I would advise you to avoid autoimmune disorders and avoid children as far as possible. Before I conclude, I'd just like to thank the people who have been instrumental in helping me understand keratoprosthesis surgery and help me develop this acumen for doing keratoprosthesis. Thank you for your attention, and I'll be happy to take any questions.